All right, our speaker today is Dr. Umbreen Mehta. Umbreen is an associate professor in the Department of Medicine with the Palliative Care Program at Johns Hopkins Bayview Medical Center, where she graduated from the internal medicine residency. She's also an associate professor in the Department of Neurology at Johns Hopkins Hospital, where she provides palliative care for people with ALS. She completed her fellowship in hospice and palliative medicine at the National Institutes of Health in 2016. After which she joined the faculty at the University of Virginia, where she was also medical director of their inpatient hospice unit and associate program director of their hospice and palliative medicine fellowship. In 2018, she joined the faculty at UCLA, where she developed the outpatient neuropalliative program in the ALS clinic. Her research interests include primary palliative care education and neuropalliative care. She's the chair of the Strategic Communications Committee of the International Neuropalliative Care Society and co-chair of the Northeast ALS Consortium Palliative Subcommittee. She served as past chair of the Neuropalliative SIG of the American Academy of Hospice and Palliative Medicine, and she'll be speaking today on a topic that is very interesting to me, very complex part of our roles within the ALS clinic. I think very needed and very rewarding, honestly, part of our jobs too. So looking forward to your talk today, Umbreen, and go ahead and take it away.
Thanks so much, Keith, and thanks for having me. I really am excited to be here, and didn't know I was the last of the series, but hopefully this will be an exciting end, and I'm hoping to spend a lot of time on questions and conversation than on telling you information that I think a lot of you probably already know, but I think and have a lot of experience with through the career that you've had. So I think the questions that always come up in terms of complex conversations about feeding tubes, it is, who should be talking about them, when and how. So I'll just jump right into it. I receive honoraria for some education that I've provided. But we're really going to talk about the significance and causes of weight loss in ALS, which again, probably more of than I do, but and you've certainly dealt with more of the consequences of weight loss and appetite loss for this disease. Decisions about the feeding tubes and the artificial nutrition, and to know who can and should be having these conversations and discussions with patients and care partners, and to understand when to have these conversations. And, hopefully, I think each one of these could probably be an entire lecture on their own, especially the last one with talking about, how to have some of these conversations, but I hope that there'll be some practical tips that you can take away. And there are courses, if you really wanted to get more skills and training in that, then that are available as full professional courses through outside programs. So let's talk a little bit about weight and appetite loss. I think the reason that this topic is so important is because, weight loss itself is a negative prognostic factor, both for mortality and morbidity for this patient population. And many of the patients that we see on day one have already started to lose weight or have lost their appetite or both. And so, it's a huge component of quality of life. And that's why a palliative doc thinks about this and sees this and talks to their patients about it. I often am getting patients in the clinic who the nurse practitioner in our clinic, her first conversation with me is, this person has lost their appetite. Can we try a medication for it? And the short answer is there are no good quality data studies on treatments for weight loss or for medication wise for weight loss and appetite loss. And so that's why, there really isn't a simple fix for it. When we think about the rate of weight loss from onset to diagnosis, it's independently related to the ALS outcome. So the rate of change doesn't really help to guide when to have these conversations or how to have them. But yet we know that patients who have a very low BMI, especially in this patient population, have a significant mortality rate. So we need to be having these conversations. And 15 to 55% of the patients will suffer from clinically severe weight loss. So again, the necessity is there. There were some data that suggested, some studies that suggested that at diagnosis, if patients have had a greater than 10% weight loss, their prognosis is 17 months versus 35 months if it's been less than 10% for their weight loss. So again, just some tangible data to really emphasize how this is not just a preference or not just a quality of life, but a quantity of life issue as well. And we did,
Umbreen, real quick. I don't think your slide advanced.
oh, I'm sorry about that.
We're still on the objectives. There we go.
Ah, thank you for telling me that. Yes, so those are the data that we were talking about. So when we talk about there are weight loss is multifactorial in this patient population. And then there's appetite loss, which we looked at separately, and I'll talk about in a second. But for the causes of weight loss, there are many causes that are really difficult to manage and almost never go away, and that are primary results of ALS itself. Patients develop malnutrition, they have hypermetabolism just from the disease. So it's, a lot of times when we're talking about families will, tell the patient, like, you need to eat, you just need to eat. And it's like they're consuming as much as they can. And it's not really something that they're going to necessarily be able to change. And we have to kind of reset the expectation that it is their disease. It's not their effort that's resulting in the weight loss. And obviously dysphagia adds to that. The appetite loss itself, I think, is notable to be separated from the weight loss. So the appetite loss, this was actually an image from a review paper that I led with actually Max is the first author on this. He's a speech language pathologist down in Brazil. And we wanted to understand, because I think when we talk a lot about in the medical world, weight loss, we kind of overlap that with appetite loss, but we don't really think of appetite as a separate, at least from, the palliative hat on my head is thinking of it as a separate symptom. And I think sometimes in the neurology world, the neurologists combine the two. But that's partly because there's a lot of overlapping in causes of appetite loss. The functional impairment that the disease causes often includes anxiety. It leads to anxiety and depression, which can cause weight loss or appetite loss, and weight loss. The duration of the disease, like how long they've been living with this, their low functional scores and older age are all kind of components of they both cause appetite loss and are a result of an appetite loss. For patients with bulbar onset disease, in addition to all the functional discomfort, there's also a lot of discomfort in terms of just the fatigue of eating itself, right? I'm sure you've had a lot of patients who say, I get to the end of my meal or I get 3 bites in and I'm just physically tired of like lifting the fork, or I'm physically tired of chewing and swallowing. And so I've had everything from like the food gets cold and it doesn't taste good anymore, so I don't want to eat it anymore and I don't want to bother warming it up 6 times, to by the end I'm too physically fatigued. I'm just got to go take a nap now. So there's and then that of course adds to the mood and the disappointment in terms of the inability to feed themselves, the inability to eat the way they used to like to, all of that. There's obviously changes with the breathing, right? They have to swallow. When they swallow, they have to be able to hold their breath. If they've got non-invasive ventilation on, being able to actually take the bites or take a break from the ventilator, the non-invasive ventilation masks, or even if it's a nasal cannula, sometimes they need to have that space to be able to swallow. So those are kind of limiting factors. And then, I think just the, sometimes there's things like early satiation. They have a couple bites and they feel really full. So there's a multitude of factors. And for appetite, like I mentioned, recently there's been more and more conversation about can we use medicines like dronabinol or Marinol like we do for people who have cancer? Will that impact their appetite? And I'll be curious at the end, or if anybody wants to comment in the chat, if you've seen patients receiving dronabinol for appetite, and if you've seen it work. Anecdotally, per my side, I have not seen a significant improvement. There's no RCTs for this or randomized controlled trials or really good data. There have been some studies, but they're not robust. And so I think it's kind of a hit or miss. If it works, great, because it has very low side effects and it doesn't have a lot of drug interactions. And if it doesn't work, no harm, but it hasn't helped much. So thinking about the feeding tubes and the artificial nutrition, because that's the best management of weight loss and not necessarily appetite itself, but weight loss itself for this patient population. We know that feeding tubes significantly extend life for this patient population. When patients with ALS have limb onset ALS, where it starts in their peripheral lower extremities or their upper extremities, a feeding tube will add an additional 10 months of life on average. And bulbar onset, if it's oral, has an additional 6.5 months of life per the literature. That's because, bulbar onset has just generally a worser prognosis because you end up having a lot more involvement in the breathing and the breathing and then the swallowing. So the prognosis is already shorter for patients with bulbar onset. It is really the standard of care for this patient population that once they have a significant weight loss, or they're having a lot of distress from swallowing and eating, or they hit that FVC, or they're climbing closer to the FVC of 50% or less, then we refer them for a feeding tube. There's actually few data on the significant impact of quality of life. So we know indirectly, obviously, like it helps with things like the distress of having to eat and all that stuff we just talked about. It helps with the indirect quality of life of living longer and kind of having time to do more things with the people that you love, but it hasn't been directly directly significantly associated with quality of life. So as a palliative care doc, where do I get involved in all this discussion of feeding tubes and quality of life, especially if feeding tubes haven't been shown to improve quality of life necessarily, but improve quantity of life. And I think a lot of it has to do with the goals of care conversations I have, and that, you all have to think through as well. We literally this cartoon is like what I've had patients tell me, not necessarily with ALS, but with other diseases as well. So just as long as I'm physically able to watch football, eat ice cream, and criticize my children, that's a quality of life I can be happy with. And that's really fundamentally what we're trying to get at, right? Is what are all these interventions, any medicine, any procedure, any interventions, what is their purpose, and what is a quality of life that people want to live with? So I think that it's something where if, we can kind of help guide patients, that's a lot of times, it'll be interesting. They'll have seen our nurse practitioner who kind of introduces this idea of like, you might be heading towards it, or the neurologist who's wonderful, like such a nice neurologist. We kind of introduce it, and then patients are certainly thinking about it and it's lingering. And there's so many questions that they have between seeing their neurologist who suggests it and seeing speech pathology or seeing the actual surgeon to do the procedure. And that sometimes is where I come in and I'm talking to them about how it looks and how it's going to feel and what's the recovery time, and then what it feels like to live with, feeding tubes, and that kind of helping them visualize it is really kind of part of the discussion as well. So probably all of you have heard of palliative care, but just to make sure we're all on the same page, because, I think in the world, I tell patients this all the time, when we're when you're going to see me in the clinic, they see palliative care and they Google search it before they see me, or they Google search it after they leave. They're like, who is this doctor? What is she talking about? And I just tell them, like, you're going to see it associated with end of life and hospice care. And I'm really straightforward that they're different. I do both. I help with both, but palliative care improves the quality of life of patients and that of their families who are facing challenges associated with life-threatening illness, whether physical, psychological, social, or spiritual. The quality of life of caregivers improves as well. But to me, this quote by Cicely Saunders, who actually was given the title of Dame she founded the field of palliative care, and it grew out of hospice. She's got a really rich, interesting biography herself. But she says, you matter because you are you, and you matter to the end of your life. We will do all that we can, not only to help you die peacefully, but also to live until you die. And I think that last bit, that live until you die, is really the kind of heart of palliative care, that we're really here to help people live and transition when they're ready to transition. But even that transition is still living. So we want people to live well until they're dead. And we want the end of their life to be comfortable as well. So that's why these conversations about goals of care and palliative feeding tubes and tracheostomies, they all kind of fall into this realm of conversation, because they do prolong life, and that's important, especially if that's what somebody wants. So when we're talking about, I'll say the caveat to all the literature, at least that I have seen, has been, especially around these conversations, has been around teaching physicians and nurse practitioners and APPs, and more conversation about the interdisciplinary team, of course, the chaplains and the social workers, but I have not seen so much literature, even in those disciplines where they're fundamentally core palliative care teams. On our team, for example, in the hospital, I have physicians, we have NPs, we have a social worker, we have a chaplain, we have a pharmacist. The dietitians and the nutritionists, they all end up being in their own separate department. We're not really having family meetings with them. And so I would say the literature for your expertise, your discipline, has not been well developed. So all of the data that I have and all of the descriptions I have, they're all geared towards teaching physicians and APPs for the most part. And I actually was recently in a conversation. We were recently working in a group and writing a paper. We wrote a paper on excellence in palliative care, and it included all the disciplines, but dietitians and nutritionists were not incorporated in that. And I don't think that that's because I know it's because the standard palliative care core group doesn't tend to have the luxury of having that. But in the clinic, every ALS clinic has a different setup. And I would, like, for example, in our clinic here at Hopkins, we don't have a dietitian or nutritionist within the core group of the main multidisciplinary clinic. So those conversations about feeding tubes, like I mentioned, aren't with me and the and the person who's going to do it, or the person who's going to give the counseling on it. Versus in other clinics, there are dietitians and nutritionists as part of the speech language pathologists, the whole category, all of that expertise. I was practicing at UCLA a few years ago, and we had a speech language pathologist in that group. So it kind of varies where you go and who you have access to. And I can tell you that the conversations and teachings are not necessarily developed for all the different specialties, even the ones who are part of the main kind of core group. So that's why you'll see here, like this example, this actually came from the journal is current heart failure reports. And so it was geared towards heart failure docs, cardiologists. So that's why you see these examples here. But I mean, you could put any generalist in this provided by in terms of primary palliative care. And I would definitely put speech language pathologists, nutritionists, dietitians, anybody who's talking about anything regarding symptom management, shared decision-making, discussions regarding prognosis, discussions regarding preferences for and goals of treatment, advanced care planning. All of that is primary palliative care. That is all what you're doing when you talk to patients about even adjusting the rate of the nutrition that goes through the tube is a quality of life and symptom management. You get, that's a huge number of calls that patients call with and say, we're having a lot of heartburn or fullness or nausea. And that's, thinking about how to adjust it so that you can improve living with this life prolonging therapy because it's part of your goals. And when it's no longer part of your goals, that's also a discussion about when to stop it. And so I think all of you are doing primary palliative care. Well, I know you are. Secondary palliative care is what I do with specifically if it refers to specifically somebody who's done a fellowship in hospice and palliative medicine and was board certified in that. Or for board certified for a physician and who has done special training. If you're not a physician, you don't, I think they get a certificate programs. So that's when we talk about things like refractory or complex symptoms, when we're doing psychosocial or spiritual distress, if there's conflict resolution, like within the family, disagreements with what patients or their family and loved ones want for them, if we're talking about complex decisions, or if there's a transition to hospice that's needed. I put this in here because I think it's kind of a nice description for you all to know with the neurologists, there's been an arc in increasingly more neurologists are getting palliative training, whether formally, like many of the ALS neuropalliative care doctors that I work with are all neurologists as primary. I'm one of the few palliative care docs with a neurology interest. But there's more and more literature on training the neurologists that you'll probably be working with for the patients who have ALS, in teaching them how to do palliative care. And that's, as you can see here, talking to patients about their disease, what they already know, kind of this is communication skills, this is symptom management, aligning with patient preferences, thinking about hospice, and then really thinking about all of our care as a team approach. And you're part of that team. So knowing what your counterparts are getting educated on will help you know where your gaps, why you're getting gaps when you're getting them. And I think there are still a lot of gaps that the neurology world is trying to fill. And that's what this kind of movement of neuropalliative care is moving towards, trying to educate the primary neurology and primary teams. Which is why doing this lecture series, for example, is so awesome, because I think just you getting these skills now can bring you back into even, filling in gaps when your colleagues don't have the education, for example. So I think this is why it's so important. And this was the, kind of a nice, so we did this study to look and see who is out there in the teams, and kind of give us a sense of where can you actually get palliative care, and where, what kinds of clinics have what services, to give us a sense of who are we working with and how can we maximize the teams out there? So we did a survey of 6 clinics across the country at academic centers. They all have neuropalliative care docs because we used our connections in the neuropalliative interest group to do this. So the 6 authors are all neuropalliative care docs. But what our intention was to show that even with very specialized option of neuropalliative care, there's still large gaps in, like, there's no unification across the teams, right? So if you look at the speech therapist, for example, most everybody had one, but I can tell you, well, University of Colorado didn't have one. They're a very big clinic. And I can tell you here at Hopkins, we don't have one in the clinic. This is like in your multidisciplinary clinic. So for us, for example, you have to go and see your speech therapist separately. You go and we don't even have a dietitian, nutritionist. Like, our nurse practitioner in our clinic is the one talking to patients and families how to adjust their tube feeds. So it's a wide variety, which is why you're going to get a wide range of who has these conversations, how do they have them, how good are they, those kinds of things. Yeah, we really do. You should come on over. So this gives you a general sense of like what's going on out there. So because most people do not have specialty palliative care, so when they do, this is how it often goes. It's there's no easy way I can tell you this, so I'm sending you to someone who can, and that ends up being a palliative care specialist. But in some ways, it's probably also you all, like, you probably get a lot of gaps in knowledge when you see patients, get referred to you, or when you have to see them, and you're like, did nobody tell you what the basics are in this? And they leave it to you to do that, and that can be really scary. So when we see, to give you a general idea of how like we manage all these different symptoms in palliative care, right? So we're trying to help kind of across the broad range for quality of life. This was in a study that I did from using the UCLA clinic patients, where we looked to see, who did I see? I was embedded. I saw every single patient who came, who was willing to see me or could afford to see me in terms of copay of coverage. And, obviously, like, there was a huge range of these things. Poor appetite was definitely high up there. And we also talked a lot about goals of care. And in that, I didn't particularly think about appetite and weight loss, but we, like, high up there are feeding tubes in terms of conversations. This was the content of my conversation on the very first day. So 94% of patients are thinking about this, wanting to know this right off the bat, and somebody's got to talk to them about it, whether it's me or the neurologist. Many times it's more than one person, right? Many times it's the neurologist and me and you, and the social worker, all of that. So it's just that it shows you how important this conversation is for people. It's like one of the first things they think about. But we're not everywhere, just like you saw. And we're also not necessarily, even if places have they don't have a embedded palliative care doc, or practitioner of some kind in their multidisciplinary clinic. Even if that's the case, they still, like, there may still be a self-standing, separate out clinic, palliative care clinic on its own. And many times they're not getting all the referrals they could be. And sometimes, especially for neurological illnesses, the reason is that the primary team isn't sure which physician should take the lead on these conversations. They aren't sure when to do them. There's obviously limitations that are inherent to just neurological illnesses themselves. 50% of patients with ALS develop frontotemporal dementia, so they cannot engage in those conversations. And then, of course, there's a lack of specialists, as we said. The non-cancer disease trajectories they're just they're just coming up, so neuropalliative care is a young field. There's just starting to be literature to really do some of this guidance. So it kind of is a self-fulfilling prophecy sometimes. So all of this to say that you being able to engage in some of these conversations and feeling comfortable, at least knowing, maybe you don't do them yourself, but you know when to send them back to your neurology colleagues or your other palliative colleagues and say, hey, I see issues, you should probably address them. Even if you can't, because you may not have time. You might have, many times the clinic visits are just, you got to do what you got to do medically wise, and you don't have time to have the goals of care conversations. So when do you want to initiate? So, we know that the timing of PEG placement does not impact survival. So you have some wiggle. The timing itself, the PEG itself helps with survival, but the timing of placement doesn't. So you have some wiggle room. Like, you're not going to go wrong if you miss an opportunity because the patient can't process it. Then, maybe they need to come back, and you do an introduction and you say, here's some information. When you come back for your follow-up, we'll talk about it some more. Obviously, we are looking for FVC changes, and when the patient's getting closer, we try to get ahead of it. So that's a good kind of box to tick in your head to say, oh, maybe that's one. When patients are younger, they have a better prognosis. So if they're older, the age of the disease onset might help to guide if you even want to offer a PEG. And there are other comorbidities, obviously, as well. So it's not a specific cutoff, but it's one to think about. If they're older, you may need to want to have more of a conversation about what is this going to do and how it's going to affect your quality of life and how long it's going to prolong them for, and do they really want to prolong their life at that time. Obviously, when they have a low BMI with less than 20, if they're having recurrent airway secretion accumulation, then the feeding tubes can be helpful. Patients who are dependent on non-invasive ventilation may actually not want or be able to tolerate a PEG. And the patients or care partners, whenever they ask, right? So that's kind of the caveat to all of it, is they may not meet any of these criteria, but they want to talk about it. And so and that's when to start engaging. These are triggers for serious illness conversations that apply to any complex decision. And so, whenever they're diagnosed with a serious life-limiting or chronic life-altering illness, like ALS, when they have a change in their health or functional status, like they're having more falls or they're having disease progression at a rapid pace, they're having increasing caregiver needs, if they have cognitive impairment, if they have other challenging symptoms like intractable pain, which doesn't happen so much in ALS, but like challenging symptoms in ALS could be secretions, oral secretions that are causing a lot of drooling and discomfort. If there are psychosocial issues like caregiver distress, family conflict, hopelessness, difficulty coping, that last two are really in the category of existential distress. Signs of a poor prognosis, unintended weight loss, recurrent complications or hospitalizations, the burden of medications are outweighing their benefits, or they start to ask about hastened death. And no matter what state you're in, I think hastened death can be kind of, whether you're in a state where it's legal or it's not legal. I've practiced in both. And, I think it's an opportunity, whether you personally believe in it or not, it's an opportunity to explore further what is going on. Like, why are they asking about this? Is there more existential distress? Is there a family situation going on? Is there a financial concern? Are they worried about how many bills they're racking up for their family? Things like that. So these are just opportunities to look for, to say, like your spidey sense can go up and say, I think we need to have some conversations. Prognostication is really hard. We're all really bad at it. I literally talked to a family about this today. We just don't see people necessarily continuously enough, depending on the setting you're in. But this top picture is really associated more with ALS. You have this kind of slow, steady, they're holding on to their function, nutrition, cognition, and then things rapidly decline until they die. And this can start to, now with the new drugs that have all come out, this kind of decline is a little bit less steep, but once they start to change, they start to change fairly rapidly. This is like, chronic heart or lung disease, where they have these episodes, they land them in the hospital, then they slowly get a little bit better. They're never as good as they were before. You never know if this is going to be, this bottom is going to be the end. And so it's really terrifying and emotionally distressing. This is like dementia and frailty. And this is like a stroke, where then they get better and they have bumps along the way, and then they slowly decline over time. So this kind of gives you a general idea of what to expect. And it helps in talking about kind of as you see issues come up. But obviously they're really, really broad stroke, big pictures. So in ALS, we kind of mentioned this a little bit, other things that can help to guide when you're going to do goals of care conversations. If you see poor survival factors, right? Risk factors like bulbar onset, like I mentioned, versus limb onset, which is more common. The limb onset is more common. The symptom onsets after 80 years old versus 40 years old. Patients who are younger than 40 tend to live longer than 10 years, just generally. And then if they have simultaneous frontotemporal dementia, they don't do as well. There are some mutations that have been associated with a shorter survival, like the C9orf72, that tends to be a little bit worse off versus like the SOD1, which now has a treatment. So that's almost, it's a new exciting drug, tofersen, that's come out that targets the SOD1 gene and could even possibly be curative, kind of like immunotherapy for cancer, but it's too early to tell. So we're still going to see. There is actually no difference between sporadic and familial ALS. Like once they get it, it's kind of the same disease trajectory for them. So that doesn't affect their prognosis. But if they have a shorter time between when they have symptoms and the diagnosis, that suggests an aggressive disease. And it's very ironic because patients who have spent years and years looking and searching and trying different, I've had patients who have come in having had done IVIG treatment, which is really no joke, they've searched and searched for answers. No one can give them a diagnosis. And finally, they have enough symptoms to make a proper diagnosis. They tend to do better. So it's emotionally distressing and traumatizing, really, but it also is a little bit better outcome. There's a great Golden Girls episode on this concept. If anybody's interested, it's Dorothy develops chronic fatigue syndrome, but nobody believes her. And she finally gets an answer from somebody. They basically were telling her, this is all in your head. You're just 50. This is what happens to women when they get old. Some neurologist tells her, go dye your hair and buy a new dress. You'll be fine. You'll feel better soon. And she finally gets, they say, oh, this is a new diagnosis in the field, chronic fatigue syndrome. It's brand new. And just the label, just someone believing her brought her immense relief. And so it often reminds me of this, where you finally get a diagnosis. It's a terrible one. It brings on relief, ironically, but yeah, Erin, it's a great episode. I would highly recommend it to anybody. But it's almost better if they have a longer time. So we'll finish out our conversation today with some tips about discussions around complex decision-making. It's not going to be, these were all developed for physicians. So know that there are educational courses out there. I'm not going to, I don't get any kickback from it. But there's more out there if you want to. These are the existing methodologies. There's more. There's one, for example, called Vital Talk. But there's so many out there. And on the bottom, the reference for this, you can see inpcs.org. That actually happens to be, they have an entire education curriculum for free on the website that was developed by a bunch of neuropalliative care people, experts. And all the slides are free, so feel free to go and take a look and, copy and paste. But I took they're meant to be used in lectures like this, so I've taken them from there. And they're all well referenced and literature based, so you can know that you're getting high quality information. So we're gonna just briefly focus a little bit on the spikes and the nurse, because those are the most commonly referenced ones. And there's open-ended questions. That's just a general technique. Reflection statements, hope and worry statements. I really hope that this works out, but I'm worried that this isn't going to help you. Most of the time, most of what palliative does is, I tell the learners that I'm with, if you're talking more than 50% of the conversation, you're probably not doing it right. There are times it's appropriate, when you've already established rapport, but if you're trying to make decisions together, you shouldn't be doing most of the talking. You need to know what your patients and your families are thinking and feeling, and sometimes they don't talk. So sometimes these are the conversation techniques that can be really helpful to get them to reflect and to talk and to open up. I think just being respectful and asking for permission to share information and to talk about these things will be, if you took only one technique away, that would be it. Like, are you okay if we talk about these things today? Are you, your family member asked about prognosis. Do you want to hear that? How much do you want to hear today? How do you want to hear it? Those kinds of things. You bring the power back to the patient and the family, and that goes a long way. Intentionally, like, it's not just to get what you want out of it. It's actually to get what they want out of it. That's the whole purpose, right? So managing emotions is when we use, so there's this mnemonic: nurse, name, understand, respect, support, and explore. And these are examples. You'll have this reported in these slides, but I think being able to name and acknowledge the feeling that somebody's experiencing, understanding what it is that they're experiencing when they're feeling this or when they're hearing this information. Were you expecting to hear this? That's one of my favorite questions. I have a really hard thing to tell you. Would it be okay if I shared this with you today? Would it be okay if I gave you my advice after we've talked about things? All permission asking statements, right? And then you share information, and then you say, are you surprised by this? What were you expecting? And sometimes I'm surprised that they had no idea, or I'm not surprised. I'm surprised to hear that they absolutely knew what we were going to tell them, and they were expecting it, and whew, what a relief. Everybody's on the same page. Now we can move on. If they're utterly devastated and they're so surprised by this, you shouldn't keep going. You need to give them time to process, just like anybody would need, right? So you want to respect, you want to show respect, show respect for what they're all doing and working on. They're your partners in this. So if you think about this as when you're working on a team and you appreciate your colleagues' expertise, you're appreciating the patient's expertise and the care partner's expertise of living with this, right? So that's how it helps me to remember, we're literally on the same team. I've got my neurologist, I've got my speech language pathologist, and I've got my patient, and we're all working on the same project. You want to support them, right? Convey non-abandonment and explore the sharings of their concerns. So that's kind of, these are because it's really scary when someone breaks down in tears, and we want to fill the gap in with more information, but really instead it should be a point where we stop and we acknowledge how they're feeling. We process through that first. And if that's all you can get through that day, okay, we'll come back and do a second part or a third part or a sixth part, and that's okay too. In neurological illnesses, we have a lot of communication challenges. We know that. So communication challenges in neurological illnesses include cognitive impairment, aphasia, dysarthria. We just have to allow extra time for these conversations. We often will use augmentation devices, whiteboards or picture boards, or their speech to text, text to speech devices. And we have to remember that the person is still there. And many times it's very easy in these family conversations to just talk over the person and move past their ability to type and text quickly enough. So we really want to pause and just give them the time they need. And then try to do some simple yes, no questions. Even though I was just saying we should do open-ended, but these are the limitations that we have to work within. So I'm hoping that after today, you appreciate more the weight loss benefit from feeding, the benefit that feeding tubes have for patients who have weight loss. The discussions around placement of feeding tubes can be led by all healthcare team providers like you. And there are prognostic factors and disease characteristics that can help you trigger when you should do conversations yourselves or turn it over to your colleagues. At least put that flag out there. And the patients and care partners initiate these conversations often, and that is the time to talk about it then. There are these conversation techniques that exist and are available. And I think on my next slide, yes. So those are the two, there's other ones. I thought these would be the two most relevant ones for now. The INPCS is the International Neuropalliative Care Society. I have that there because of the free educational stuff that includes this curriculum. And I also include this palliative care fast facts. It's made through the University of Wisconsin, and I literally studied for my board from this. It is like I give it to my fellows. It has really nice content that's, again, written by palliative care just generally, and it includes conversations about or topics they're like one-page readers that have well referenced and include all conversations or all discussion points. They include knowledge on cardiac and geriatrics, and they're disease based as well. So I highly recommend that. And that's my email address there in case anybody would like to reach out or have any questions or anything like that. So yeah, thank you very much.